All right. And now we will go live, and I'll give it a second when I go live just to make sure it pops up for me, and then I'll go ahead and start. And oh, actually, super embarrassing moment for me, but just want to make sure, am I saying your name correct? Dr. Bollens?
It's perfect.
Okay, just want to make sure. And how do you say your first name?
Now, yeah, my first name is Renaud.
Hanu?
Renaud is a bit more difficult to pronounce it for you. Renaud.
I was gonna
It's,
say, is it okay with you if I just say Dr. Bollens? Because I
yeah,
don't
it's
want to
perfect.
butcher your name.
It's
I should have
perfect.
practiced that beforehand. That's so interesting because it's spelled like in English it's spelled like Renard, I think in English.
Yeah, yeah. It's usually English people pronounce it my name like that. Renaud, also
Renaud.
Renaud because it's AUD, and it's
Yeah.
really difficult for them.
For me, I was born in Poland, so for some reason for me, I want to like roll the R, but for you it almost sounds like it's silent. Can you say it one more time?
Renaud,
Renew?
Renaud is the O,
Ooh,
Renaud,
okay. I'm not
because I
gonna do it because I don't
want to
want to
try
embarrass
to.
myself. But that's fascinating because yeah, I was looking at it and I was like, I don't think I've ever heard um someone say your first name. It's always your last name. And I'm like, I should ask just in case. Okay. I'll just say Dr. Bollens. So I apologize. That's my bad. I should have practiced that beforehand. Okay. So I'm gonna go ahead and start it. You ready?
Yep.
All right. I'll let you know when I see it pop up. Still, still don't see it. Okay, I think we're up. All right, just want to make sure that the chat is up and running. Okay. All right. Okay, I'll go ahead and get started. So, hello everyone. My name is Kora Peck. I'm on the board of directors of a nonprofit called Pudendal Neuralgia Association. We would like to remind you that the information shared in this interview is not intended to replace medical advice, and it is not a substitute for specific advice concerning individual situations. I am joined today with esteemed urologist Dr. Bollens to talk about his expertise in pudendal nerve decompression surgery. I would like to start by asking Dr. Bollens, could you please tell us a little bit about your clinic, the location, and any recent changes you would like to share?
Yeah, good morning. I'm doctors from Belgium. Belgium is a very small country near France, between France and Germany. And my hospital is in Tournai city. It's a small city, 15 kilometers far from the French border. This is my main location, but I also operate in a different place. But for the patients coming from abroad, it's organized at that place because the administrative system is well organized, and particularly people are able to speak English. It's much more easy for patients who are coming from abroad. In the near future, I will also probably have an activity in Dubai. Why in Dubai? Because some of my patients cannot obtain a visa for the Schengen space, particularly when they are coming from India, for example. Then we have decided to find a spot, a place where they are not so close, and they open more easily the borders for the patients who need to be operated. Is the reason why we choose Dubai.
All right.
I don't know if it fits enough for your question
It
about the
is. That's
location.
great. Um, and is there, I noticed you also have a new website. Would you like to talk a little bit about that as well?
Yes, yes. And then the problem, of course, is my medical activity started to grow very quickly, and I was completely overflowed with all the contact of the patients who call me from abroad. Then my private life start to suffer from that situation. Is the reason why we try to organize a little bit more just to don't be completely crazy in the near future. And it's the reason why I'm associated actually with a few peoples who take care about the administrative aspect and also the financial aspect. Of course, it's increased the expenses due to the fact that you have more people involved in the treatment of the patients. In the other hand, our goal is to avoid that somebody stay without treatment if they have some financial issue. Then we charge more than what I charged when I was alone. But the idea is also to have somewhere a little bit of money on the side if somebody needs really surgery and if he has a financial issue. And one of my messages, of course, we have the normal price, but if somebody has a real financial problem, it's not a shame to discuss that openly. We are open to discuss with them to help everybody and not only the patients who can afford the amounts to be operated.
Wonderful. Thank you so much. And we're so very happy to have you. A lot of our members are very much looking forward to this. So I'm going to go ahead and get started with some of our members' questions. The first question we have is, what is the difference in symptoms for pudendal nerve entrapment and pudendal neuralgia?
Well, in the terms neuralgia, it's include pain. It's the algia, is the pain. And the problem is historically we have a bias in the understanding of this pathology because the first centers who take cares about this pathology were a neurological center. And the recruitment that they have is mainly painful patient. I'm a urologist, and for this reason, I have on the side of the painful patient, I have also patients with functional problems. And this is very important because probably the majority of the members that you have in your in your group suffer from pain, but in reality, probably the majority of the patient suffer from functional problem, and a part of them suffer also from pain. And it's just two different symptoms. You have the pain on one side and the functional problem on the other side. But it's very important to realize that you can have one without the other one. Then you can have just the pain. It's unusual because the diagnosis is based on the fact that when you discuss with the patient, we realize that they have a functional problem associated, and the pain is the first symptoms that they explain. But when we discuss with them, we realize that they have other problem like premature ejaculation, urgency to pee, or other symptoms of sexual disorder. But you can have just the functional problem without the pain. That is a bit the difference. I think that pudendal neuralgia is for me not the best word because it's exclude by definition the functional problem.
Okay. And so for pudendal neuralgia entrapment, then, have you ever had it where, or is it common, I should say, for symptoms to be 24/7? So if someone has entrapment, is the symptom all the time, or do they have periods where the symptoms are a little weaker and then return to normal?
Yeah, it's a particularity of the pudendal symptoms because majority of the patients have a cycle of symptoms. And for example, it's really common that they have a lot of symptoms during the day and no symptoms during the night. I remember patients who had to pee each 20 minutes during the day, but she was able to sleep all the night without a problem to go to the toilet. Why it's like that is because in the majority of the case, the compression is a dynamic compression. It's a compression not in the alcohol canal, because we always speak about the alcohol canal, but the alcohol canal compression concern only 15% of the case, 1/5. Majority of the patient had a compression which is more proximal between the piriformis muscle and the sacroiliac ligament. And in that level is the muscle who is contract and push on the nerve. It's the reason why during the night when you are asleep, all the muscles are relaxed, then the pressure disappears and the symptom disappear too. Then if you have symptoms 24 hours on 24 hours, the first thing you have to exclude that you don't have another problem, because when you have pain, it's a compression between your brain, who feel the pain, and the place where you have the sensation to have the pain. It means that you can have also a compression in the cervical area. It can give you also perineal pain. Then if you have pain 24 hours on 24 hours, it's important to do to check with the MRI all the vertebral column to be sure that you don't have a hernia or stenosis of the Rachidian canal or something like that. Okay. But of course, also, if you don't have symptoms during the night, it means that the nerve have some period of during the day of recovery, and you can be sure that the situation is still reversible. Somebody who develop pain 24 hours on 24 hours or symptoms 24 hours on 24 hours, it means that maybe we have to operate or to decompress the nerve faster because we have the risk to finish with the irreversible lesion. That's the problem. When you compress the nerve, at the beginning, it's just a small ischemic lesion, but the structure of the nerve is not injured. If you push it a bit harder, you destroy the myelin structures around the fibers, the nervous fibers. And if you push harder, you destroy completely the fibers. Then you have different level of lesion of the nerve. And depending on in which moment you are, you can have a reversible lesion or irreversible lesion. And of course, my message is we should not arrive in the irreversible lesion. We should decompress the nerve faster as possible when we start to have the symptoms. It doesn't mean that we need to operate all the patients, and because we have a conservative treatment, we can decompress efficiently also the nerve. It's also important. But if the conservative treatment to decompress the nerve doesn't work, the second step should be the surgery. I see many people taking who took Lyrica or pregabalin for years. It's important to remember this kind of drug just reduce the speed conduction in the nerve, then you don't feel so much the pain, but the nerve is still compressed, and this danger is to have a finally after years of treatment irreversible lesion.
And would you say that this means that there's an appropriate time to consider surgery? Is there such a thing as getting surgery too late where you can't correct it?
For me, you have 2 points. The first thing is don't wait to have symptoms during the night. That's if you start to have symptoms during the night, it became urgent to do something. The second point also is the type of symptoms, because if you press a little bit of the nerve sends more false information in direction to your brain in the sensitive fibers, and also more stimulation in direction of the motoric fibers. It means that at the beginning, it sends false information, gives pain, but in the other side, through the motoric fibers, it will give a spasm of the sphincter and hypertonicity of the sphincter, of the muscle, okay? If you continue to press more on the nerve, you stop completely the influx, and you can pass from hypersensitivity and pain to a numbness, and then you don't have the pain at all because it's completely numb. And in the opposite, instead to have the muscle who are spasmed, you can have a palsy of the muscle. Then if you have palsy of the muscle, like a weak sphincter, for example, like a weak tonus sphincter, and numbness, it's a worse situation that you have a hypertonicity of the muscle and pain. Then this is also the key. If you have that kind of symptoms, numbness instead of pain, and muscle palsy instead of hypertonicity of the muscle, the situation is worse. It's also more urgent to operate.
And how do you determine what surgical method is most appropriate for a patient?
We use always the weapon that we have in our armamentarium. For me, I operate laparoscopically because first of all, it's a minimal invasive approach. Then the surgical access itself is not really big. It's like if you remove a gallbladder, it's nothing more than is after 1 day or 2 days, the patients are fit. When you go transgluteally, you need to sacrifice a part of the gluteus muscle. And when you cut the muscle, you can create some pain due to the access itself. And this is also one problem. The advantage with laparoscopy, we can really release from the beginning of the sacroiliac ligament around, we go to the sciatic spine and we open completely the Alcott canal. Then the advantage is the main part, who's usually where we have the compression, is completely free. The only thing is, if you need to have a surgery at the level of the perineum, for example, if you have a cluneal nerve, laparoscopically, it's impossible to release the cluneal nerve branch in the same time. But personally, I think that we should try a minimal invasive access as first, because we know that you have between 80 to 85% of success. And after, if it doesn't work, you have to consider maybe another approach to check more distally the nerve, for example, or to see if you don't have another problem.
Sorry, I'm having difficulties with my camera. Sorry. There we go. Hopefully it works. And so now I'm curious, approximately how many PN decompression surgeries have you performed? And can you tell us the success rate you've seen?
Yeah, actually, we have operated more than 500 patients, and we operate each year something like 100 cases, 120 cases, more or less, roughly. The success rate is between it's around 80% of the case. But the problem is, of course, what do you mean about success rate? I say always to my patient, the question is, are you happy? But happiness is something which is really subjective. Some patients want to do everything. They say, particularly the young people, they say, no, I want to be able to return on my horse or to take my bicycle. The other people say, okay, it doesn't matter, I will not use my bicycle anymore because I know that I have a worsening of the symptoms when I use the bicycle. Then the question is finally, what about the quality of life? When you have that, 80% of the patients are happy after the surgery. But it's also very important to define the moment when you ask the question. If you ask that question during the first months, probably 90% of patients are not happy. Why? Because during the first week, due to the general anesthesia, the symptoms disappear completely. You can have, I remember I had one patient from US. She had a general anesthesia each 10 days just to survive. Like that, she was without pain for 1 week, and then she organized the next general anesthesia. But after the surgery, 1 week later, in 50% of the case, the nerve will wake up and you have a reinnervation allodynia. It means that the symptoms can become much worse than before the surgery. I have 3 of my patients who tried to commit a suicide during the first month because they were so desperate. And it's very important to inform the patient because, of course, for them, it's psychologically very hard when if they are not informed that they can have this kind of flare-up after the surgery. And it's the reason why when you ask what is the success rate, it's important to let the time, to give the time. I say more or less after 6 months, the recovery is 80% of the symptoms. But I have some patients with 90% after 1 month. I have also some patients who need 1.5 years before to feel the first sign of allodynia, who is the beginning of the recovery. It's depend of the age of the patient, of the fact that they have a long story of symptoms. If they have symptoms 24 hours on 24 hours, if they have a positive answer to the infiltration test block, then you have some individual parameters who change the prognosis also.
Okay.
I have some patients who arrive with the desperate situation. I know that the success rate will be maybe 20%. But when you do a laparoscopic approach, it doesn't matter. I told them we can try. It's 20% of chance, but it's just 4 holes in your belly. If it doesn't work, you will have just 4 small scars in your belly. It's nothing. And majority of the patient without good success rate didn't regret to have tried the surgery because they say they didn't pay anything after because they were operated. It was just a failure of the results.
And have you ever had patients get worse from laparoscopic decompression surgery?
When patients ask me what is the risk of the surgery, I always answer the same. The first thing, you can die, and between that and nothing, you add what you want because it's the surgery. Then, of course, you can have a worsening of the surgery after a surgery, but it's very rare. It's like when you take your car, you know that you can die on the road, but you continue to use your car. What I've seen in terms of worsening I have one of my patients who stay with the palsy of the obturator nerve. Is due to the fact that in some angle, when you enter with the instrument, the nerve, the obturator nerve can be compressed if we don't take care enough about that. It's for this reason that we change the position of the trocar. We put the trocar more medially to minimize the pressure on the nerve. But I have one of my patients who stay with the palsy of the obturator nerve. The other problem is sometimes you have one specific problem with the hard flaccid syndrome. Is a patient with a penis who stay always a little bit half tumescent, but when they want to have sexual activity, it doesn't work because they have a compression of the venous system, but also the arterial system. And when you operate them, you release the artery, then usually the flow for direction is better, but you release also the vein. And then it means that suddenly, when in the flaccid position, the penis became a little bit smaller. And that kind of problem sometimes is not well accepted by the patient. Suddenly, they have the sensation that the penis is shorter after the surgery. But we cannot say that it's a failure, it's a logical effect of the decompression of the venous system also. But we have to inform the patient about that possibility, of course, because like in all functional problem, we have to give the best information as possible, and at the end, it's the patient who has to decide if they want to be operated or not.
And can decompression surgery be repeated if there is re-entrapment post-surgery?
We always speak about re-entrapment. I don't like that term because if you don't want to have fibrotic tissue, you have to operate a cadaver. If you operate a live tissue, the first reaction of the body of the tissue will be to create fibrosis to try to repair the tissue. It's happened at the beginning. I returned in the patient with the recurrence of the symptoms, and I was really surprised because I was sure to have cut the ligament, and when I returned the patient, I found a tissue who looks like a new ligament. And I say, well, come on, I'm sure to have cut this ligament, but it's just a fibrotic tissue who repair what I've cut. And I think that at that time, at the beginning, we tried to cut a second time. But I think that when you have this situation, you have to change your mind because you are it's blocked between the ligament and the piriformis muscle. But what we do actually, in case of recurrence, we go from the other side. If it doesn't work when we cut the ligament, we sacrifice the piriformis muscle. Then we can sacrifice the piriformis muscle in the chemical manner. We can inject the Botox inside the piriformis muscle. It can be efficient for maximum 6 months. But if it works, it's just an intramuscular injection 2 times a year is nothing. Then for some patients, it's enough. It's a good solution. If it doesn't work or if the effect is too short, we have a new technique. We enter inside the gluteus muscle with the optic and another small instrument, and we cut the body of the piriformis muscle. Like that, we release completely the pressure from above, and we have a significant good success rate in case of failure, because the failure is probably the majority of the case of failure after the classical laparoscopic approach is probably the problem of the hypertonicity of the piriformis muscle. It's the piriformis muscle syndrome, who is not treated when we cut the ligament. Sometimes it's difficult, particularly from patients from abroad, because one of the treatment is to correct the postural problem. If your bone pelvis is not in the correct position, anteriorly rotate, it will create the piriformis muscles contraction by reflex, but it's not easy to find a postural specialist in all countries.
And so this next one's kind of a 2 question. Is nerve entrapment a possible cause for rectal prolapse? And will surgery be able to relieve the rectal prolapse symptoms?
Well, it's indirect effect. You have 2 things. When you stimulate the pudendal nerve is also a motoric nerve, will innervate the sphincter and also the muscles from the perineum. Then you have 2 possibilities. The first one is the anism. If you have the spasm of the anus due to the irritation of the pudendal nerve, of course, you have to strain very hardly to pull. And the excess of straining can increase the risk of rectal prolapse. And in the other hand, if you have a more advanced lesion, you can have a palsy of all the muscles like the levator ani muscles or the transversalis ani muscle, who can become weak. And if you have a weakness of this muscle, it's also increase the risk of rectal prolapse. And yes, probably it's one aspect. It's probably a significant risk factor to develop a rectal prolapse, but it's not the only one.
Do you see a poor surgical outcome from patients with connective tissue disorders?
The connective tissue disorder is very interesting because it's clear that we have in our consultation of pudendal nerve entrapment a higher percentage of patients with the Ehlers-Danlos disease. Is the Ehlers-Danlos, I think, is a type 3, is the visceral Ehlers-Danlos disease. The prognosis is poor because the problem is not only a compression of the main trunk, because in this situation, you can have also the injury of the terminal sensor at the end of the fibers. It is not just the compression here, it's also the end of the nerves who can be injured due to the connective tissue. And for this reason, we know that they have two potential problems. And of course, more problem you have, lower is the prognostic factor. But I think that it changed nothing. We can tell, yes, it's a lower prognostic factor. Should I not operate them? No, we have to operate them, and then we will see. And we hope to be in the good percentage, but we know that it's a bit worse prognosis.
Okay. Have you seen patients with Tarlov cysts show no improvement after decompression surgery? And if you have, do you think it's the cysts that were the main cause of the patient's pain?
The Tarlov cyst is the bottle of ink. But when you discuss with the neurosurgeon, they say that it's not significant. You have to imagine that it's just like a pouch of liquids, but the pressure inside is very low. It's the same pressure that the liquid that you have in around our brain. That is not a cyst really under pressure. And the question is, if when you have this weak cyst, if it's significant to explain that you have a compression of the nerve. When you discuss with the neurosurgeon, majority of them will consider that it's not significant.
Okay.
But I'm not neurosurgeon.
Fair enough. Um, do you operate on the pudendal and the posterior femoral cutaneous nerve at the same time? And have you seen this nerve get damaged post decompression surgery?
Well, the posterior femoral nerve is the main trunk who gives the cluneal nerve. Then it's always the question when you have somebody with the pain, if it's a pudendal nerve or a cluneal nerve or both. Laparoscopically, it's impossible to reach the cluneal nerve at the place where it's usually compressed. It's usually compressed just lateral from the ischiatic tuberosity. And that level is really inside the perineum. It's impossible to arrive there laparoscopically. And I don't operate that kind of nerve usually in the same time. The main trunk, the femoral, the femoral, the posterior femoral nerve, is the main trunk, is running at the same place that the roots of the sciatic nerve and the pudendal nerve. It means that in one point you can have a triple compression, and you can have, for this reason, also pudendal nerve symptoms, pseudosciatic symptoms, and pain in the cluneal territory. It's probably the reason why when I cut the ligament, some symptoms of the cluneal nerve can disappear because it's not a compression of the cluneal nerve, but it's a compression more proximal on the main trunk. Okay, but specifically, I don't dissect. Also, the cluneal nerve is just a sensitive nerve compared with the pudendal nerve. Then usually it's when you have patients who have really a pure cluneal nerve, it's easier to do a radio frequency or to destroy completely, definitively the nerve because it's just a sensitive nerve, then it's not a big issue. He has a lot of overlapping of the territories with the other nerves around, then it's not a major problem if we sacrifice this nerve.
Okay. And so we've heard that scar tissue tends to form in a lot of these locations post-surgery. Can this be prevented in any way after you get surgery?
No, we can. I don't believe that we can prevent because I discussed with many neurosurgeons to know if it's possible to do something to avoid that. And in fact, no. The only possibility is to operate a cadaver, as I told you. But what we can do is to try to organize the fibrotic tissue. The nerve is there, the ligament is here. When I cut the ligament, we can see that the tissue is moving up. And after you have the fibrotic tissue will reshape above the nerve. That what we have to do, the first thing is to increase the size of the tissue who is moving up. It's for this reason why I give the tadalafil 5 milligrams every day if possible, just to dilate the artery, the pudendal artery. Like that, I increase a bit the space around the nerve. The second thing, my advice to the patient is after the surgery, during the first month, every day they have to be sit a little bit, from time to time. It's very bad to stay stand up all the time because like that, you cannot push up the tissue and then you cannot manage the maximum of space under the fibrotic tissue. But maybe it's not scientifically proved, but for me it makes sense.
Okay. If someone decides to undergo laparoscopic decompression surgery, how likely or unlikely is it that they will experience incontinence? And if they do have incontinence after the surgery, is it something that's typically temporary or can it be permanent?
Well, it depends which kind of incontinence is, if it's a urinary incontinence or fecal incontinence. And of course, it can be always irreversible. If I was drunk during the surgery and I've cut the nerve, it's irreversible, but it never happens. Okay. The problem is mainly when we manipulate the nerve during a first period, the nerve is you have a transitory palsy of the nerve. And if you don't have, if you have a numbness of the anal canal on both sides, for example, if you operate both pudendal nerve, you can have a numbness of the anal canal, and then you cannot feel when the stool is arriving. And then you can have a fecal incontinence for 3 months. Is the reason why I give this information always, particularly when the patient has to be operated on both sides. For example, in Belgium, the patient who have a bilateral problem, I operate them on one side. I wait between 3 to 6 months, just the time needed to have the enough sensation coming back before to operate the other side. But of course, for the patients who are coming from abroad, usually they prefer to take the risk of transitory fecal incontinence because if not, they multiply by 2 the expenses. But the risk is not zero, but it's very low. It's like 2% of the case when you operate the patients. And in all cases that I've seen, it was a transitory problem.
Do you schedule routine follow-up appointments with your patients after surgery? And if so, how frequently?
Yeah, then it's very important to have the follow-up for 2 reasons, because all what I know because I have the feedback of the patient. The feedback of the patient is very, very, very important for our statistic, but also for our understanding of this pathology. Also, it's important for the patient because usually it's a very long recovery, and they need a psychological support. They don't feel that they go better. And I see them at 1 month after surgery. We do have a discussion 1 month after surgery because it's usually just after the flare-up. And it's important to let them know, no, the worst is behind you. You have to wait. It will be better and better. Also, I give them some trick to evaluate if the symptoms is improved. For example, you have 3 passages. The first is numbness, after is hypersensitivity, and finally is a normal sensation. And if you can feel this evolution, it means that the nerve is improved. Also, you have a wave of recovery. Usually, statistically, the recovery starts from the anus and go in direction of the clitoris or the gland of the penis. It's just because the nerve is coming from the back, then the length of the fibers who goes to the anus are shorter than the fibers who goes to the gland of the penis. Then if you can feel also this wave of recovery over the perineum, it can help the patient to see that finally they have an improvement with the time. But it's very slow, and they need help just to realize that it goes better.
And is there anything that the patient can do to basically increase their chances, like that they don't re-aggravate anything? Anything that, you know, I'm trying to think like, sitting on cushions is very common thing for patients with PN. So is that something they should continue to do?
Well, in fact, it's important to understand why the patients develop this kind of pathology. And finally, it's not just one reason, it's usually the addition of multiple risk factors. And when more you have risk factor around, more you have the risk to develop the symptoms. But also, if you want to recover and minimize the risk of recurrence, you have to suppress the maximum of risk factor in your environment. What it includes in terms of job, it means that you need to have an ergonomic seat. I have many patients who develop a problem during the COVID crisis because people are working on the chair of the kitchen instead to be in the office. Then they develop some symptoms due to that. Then you need to have an ergonomic seat. Also, each hour you have to put an alarm on your mobile phone just to stand up and walk 10 minutes just to decompress. You cannot stay all along the day in the seated position. You have to avoid some sport activity. Or more or less all the sport activity will increase the tonus of your buttock. It's really trendy actually to do a sport to have a sexy buttock, but it's not a good idea because you increase the tonus of the piriformis muscle who push on the nerve. Then no squat, no step, no bodybuilding, all the sport activity that many people does actually. And the most difficult is to correct the postural problem because as I told you, when your bone pelvis is not well oriented, it maintains the contraction of the conical contraction of the piriformis muscle. And you need to see at least a chiropodist to check if your bone pelvis is well oriented and eventually put insulin in the shoes to correct the position of your bone pelvis. But I have some patients who had a problem with the jaw. If you have a problem with the jaw, your jaw is completely not in the good position, it will influence the position of your head in the space. And if your head in the space is not correctly placed because you have a problem, it changes the position of the vertebral column, it descends all along the vertebral column, and at the end, the bone pelvis tilts. And this is also the reason why you can develop this kind of problem. Then it's important to try to control the postural problem. Also because some patients have pain in the rectum, they have the sensation to have pain in the rectum, but it's not a neurological pain. It's a pain related with the piriformis muscles contracture. And it's really common. I operate patients and we have cut the piriformis muscle and the rectal pain disappear. Then the pain is very difficult because finally is the less specific aspect of that pathology. It can be the pudendal nerve who is painful, but it can be also the muscles who is contract. And it can be another reason who create the contraction of the muscle who will create the pudendal nerve symptoms. Then it's sometimes difficult to move on the origin of the pudendal symptoms. I have patients with arthrosis in the hip, for example. When you have arthrosis in the hip, you have a conical pain. For this reason, all the muscles around the hip will become contract. One of these muscles is the piriformis muscle. The piriformis muscle start to push on the pudendal nerve, and you develop pudendal nerve symptoms. Okay, it's not so uncommon. It's important to try to understand all the chain of reaction to treat all the aspect of the problem.
Yeah. So you mentioned avoiding certain activities. We did have a member who asked, can a patient eventually achieve an active lifestyle again after surgery? Like, is there a certain time frame where they, can return to certain exercises and things like that?
It depends from patient to patient. A part of the patient will be able to take 100% your life back. The other one will be only 80%. What I say, my advice is when after the surgery, when you restart an activity, it's like the oil in the mayonnaise. You have to add little bit by little bit. Then in practice, if you want to run, for example, you have to run 2 times around the house and you see the day after how you are. If it's better, if it's fine, you can turn 4 times around the house. And then step by step, you increase the level of the activity to see what is the limit of your body. That's very important. I remember I operate a professional horse rider, and I told him you have to sell the saddle and you have to eat your horse because you cannot, you have to change your job. But in the last news that I have, he is still on his horse. And he recovered enough and he has a complete normal life now. But it's really dependent from patient to patient. But when you restart, you have to restart progressively and to observe the reaction of your body the day after. It's like when the patient has sexual activity. When they have sexual activity is the day after that they have a worsening of the symptoms. This is classical. Sexual activity is also one thing that I told them. You have to try from time to time to see if you are able to have a sexual activity in one moment. Of course, it takes times because the sexual activity for me is probably one of the strongest stimulation for the nerve. And when you are able to have sexual activity without worsening of the symptoms, probably you are completely cured.
Okay, so now we're gonna ask, these ones are a little bit different. So could a redundant or tortuous sigmoid colon put pressure on the pudendal nerve? And if so, would decompression surgery help?
I don't believe that because the pudendal nerve is extrapyramidal located, is extrapyramidally located, and the sigmoid colon is inside the perineal cavity. I cannot imagine that just because you have a long sigmoid colon, it can push on the nerve. What is true is if you have chronic inflammation of the sigmoid colon, you can have pudendal nerve symptoms. Huh? It's really common, for example, when you have endometriosis. Why? Because we have two main spots of endometriosis. One is in the fossa of the ovary, and the second one is on the uterosacral ligament. And the uterosacral ligament is really close to the sacroiliac ligament. And when you have an inflammation at that level, it can induce by proximity an inflammation on the sacroiliac ligament, and the patients develop pudendal nerve symptoms. But the length of the sigmoid colon is not enough. Another thing is the obesity of the patient. You are in US, and it's evident that some patients with a very big abdomen mass, they have a risk of development due to the pressure from above, but you need to be in really overweight situation.
And speaking of endometriosis, can deeply infiltrated endometriosis cause burning pain in the vagina or urethra? And if a patient also had adhesions, could this be a cause of their bladder retention?
The bladder retention is related with the pudendal nerve. It's one thing that people doesn't know, that the urinary sphincter is innervated by the pudendal nerve. Then it's really common. If you have pudendal nerve decompensation, you can be in your retention. Huh? I remember I operated a woman. She was 53, and she was in a complete urinary retention. And I operated her for the pudendal nerve. And 6 months later, 3 months later, she restarted to pee completely normally. And it's very interesting because also when you speak about the uretralgia, we speak about the location of the pain, because we say always the pudendal nerve gives perineal pain. The most interesting is the location of the pain. You have three places with innervate only by the pudendal nerve. It's the clitoris, the gland of the penis, and the urethra. Then if you have a pain in one of these three spots, it's 100% sure to be a problem with the pudendal nerve. And as I told you, many women who had endometriosis, probably due to the proximity of the lesion and the pudendal nerve. In fact, a part of the symptoms is related with the pudendal nerve symptoms and not the endometriosis itself. For me, that's my analysis.
So is there a specific area of entrapment, such as, in the Alcock's canal or the ligaments, that is specifically correlated to rectal pain?
Well, that's very interesting because the rectal branch is the first branch to escape from the nerve, and it escaped before the sciatic spine. It means that if you have rectal symptoms, the compression is always before the Alcock canal, or at least you have 1 point of compression before the Alcock canal. This is the first thing. You have also, in some case, a compression of just the rectal branch when it escapes from the nerve and goes through the tuberous ligament. I have seen that. I remember a patient who was operated in Vienna, and the neurosurgeon removed through the perineum completely the rectal branch because it said that it was impossible to release, and he cut the rectal branch. The patient has still rectal pain. He come to my consultation, and I say, well, it's probably because you have a compression more proximally on the main trunk, then I have to release the pudendal nerve. And I release the pudendal nerve like classical, but I didn't dissect the rectal branch because the rectal branch was removed already. After the surgery, the patients told me, I have still the pain in the rectum. Then I
Mm.
decided to return inside laparoscopically, and then I dissect the rectal branch. And what I found was from above, the rectal branch was, I try to show you, still there. And it was entrapped in the passage inside the tuberous ligament. Then I open the passage, I follow the rectal branch, and suddenly, pops! I have the tip of the nerve who was cut by my colleague who became free. I just coagulate that one, and it stopped. The pain disappear. And it was just because if you cut the nerve here, but it's still blocked, it continues to send false information to your brain that you maintain the pain. But it's one point, specific point of compression of the rectal branch. It's important because it changes also the surgery. If the patient doesn't have anorectal symptoms, I don't touch the rectal branch because it's a very small branch and you have high risk to injure or to have numbness, transitory numbness when you dissect the rectal branch. Then if the patient doesn't have anorectal symptoms, I don't touch that branch. But if we have a problem, I enlarge the passage of the nerve through the tuberous ligament.
So I have a question. Can a dislocated tailbone create pudendal neuralgia? And if so, what treatment would be suggested? Whether it would be, to go in and remove the tailbone, or would decompression surgery be
Well,
an option?
the tailbone is a big problem because nobody knows exactly why we have pain there. That's the issue. I think that the relation between the pain and in the tailbone and the pudendal nerve is when you have something painful, some muscle will become contract. If the muscles are contract and pull chronically on the tailbone, it can be a reason why you have pain. Then the question, of course, if you suppress the origin of the pain, maybe the muscle will be relaxed and maybe the pain in the tailbone will disappear also. But on the other hand, if you have a postural problem behind who create the muscles contracture, you can release the nerve, but the pain in the tailbone will stay. It's the reason why it's probably not so clear if we can control the symptoms, this kind of symptoms with a simple pudendal nerve. I think that we need to, if you have a doubt, to do a more exam, but oriented in a orthopedic point of view. It means normally you have to do a profile X-ray of the tailbone, but under mechanical resistance. Then it means that the patient is sit on the chair on the profile, and then usually when you have a problem, is when they are moving back in a certain angle, they have the pain. Then you have to do an X-ray with the maximum of pain and X-ray in the standard position. Then like that, you can already see if you have a hypermobility of the tailbone. It can give an idea if you have a problem. You can do, of course, do a MRI or you can do a bone scintigraphy to see if you have a hyperactivity of the bone in this area. And finally, you can also try to do an infiltration blood test of the tailbone to see if it suppresses the pain.
Okay. If people are showing improvement from using medication or pelvic floor PT, does this mean that the pudendal nerve is just injured and not compressed?
No, because you cannot make the difference between compression and injury. For me, on both cases, it's an abnormality of functioning of the nerve who gives the symptoms. But physiotherapy can help. The problem is many times we don't understand what we do. Then it's important when we examine the patient, they have a muscles contracture, but it's important to realize that some muscles are contract because the nerve is irritated, and the irritation of the nerve sends false information to the muscle, and then many muscles of the perineum became contract. If you do physiotherapy on this muscle, it doesn't make sense because the nerve is still compressed, and then you will not treat the problem. What you have to do is to focus the physiotherapy on the piriformis muscle because it's this muscle who is pushing on the nerve. And when you release the pressure on the nerve, the muscles of the perineum will be relaxed by themselves if it's sufficient. Okay, then physiotherapy can help, but for me it must target the piriformis muscle, and for that we have a stretching exercise of the piriformis muscle, but you have also deep massage of the buttock. The patients can do that by themselves, and they use a tennis ball on the floor. They sit on the tennis ball and they roll the tennis ball under the buttock. But for me also I don't like the internal cavity physiotherapy because sometimes the risk is to push on the wrong place and then the patients can develop a very, very bad pain. And also it's evident for me that we should not stimulate with electricity the muscles of the perineum, because many patients finish in the consultation of not postural physiotherapy, but perineal re-education physiotherapist, and it's usually not a good idea. Okay, but the drugs, concerning the drugs, majority of the drugs will just hide the symptoms. They reduce the speed conduction in the nerve, and you feel less the symptoms, but it doesn't change the mechanical compression, except one drug is the tadalafil. Tadalafil is the drugs that we give for erectile dysfunction in the men. And I was surprised because I have many young patients who had erectile dysfunction associated with the pudendal nerve symptoms. And I prescribe tadalafil 5 milligrams for erectile dysfunction. And many of them come back and told me, but it's strange, when I'm under tadalafil, the pain is better. It's so true that actually we give the tadalafil for erectile dysfunction to the woman, and in 50% of the case, the pain is improved. And it's changed completely compared with the other drugs. What is the mechanism probably of this drug? We increase the flow in the pudendal artery, but it's the pudendal artery who gives the oxygen to the nerve. Then when we took the tadalafil, we improved the healthy, really the healthy of the nerve. And for me, it's not the same goal. It's really to improve the nerve. The other one is just to hide the symptoms.
And do you have a recommendation for a good cushion for people to use?
Well, the cushion, it's a point of view. I say it's always a question of comfort. If you found the cushion who is good, that's fine. But if you use a donuts cushion, for example, you suppress completely the pressure on the medium part of the perineum, but you increase the pressure on the tailbone and on the cluneal nerve. Then if you feel that you have a new pain, maybe you have to stop to use this cushion. Personally, also when you, for example, when you drive a car, if you use a donuts cushion, it's very difficult because it's unstable. And I prefer to use a cushion for paraplegic patient. And it's a cushion not too big, because there's different model. You have model very big, and this is not good for pudendal nerve. I use a cushion thick like that, more or less. It's the name is the honeymoon technology, not honeymoon, honeycomb technology cushion. Is a silicone structure like that. It breathes through the cushion if you have to sit for a long time, and it gives a homogeneous pressure under the buttock. And for me, I prefer that kind of cushion. But you don't have a perfect cushion for everybody. I think that you have to try many cushions and see which one is efficient for you.
Okay. If a patient has left-sided pudendal neuralgia pain all along the pathway, but they also have an unstable left SI joint, could that be related to the patient's PN pain?
Yes, because the SIG, the sacroiliitis or the sacroiliac joint problem can create a muscles contracture by reflex. If you have a problem at that level, it's painful, and it's really common to have the pudendal nerve symptoms associated, because the piriformis muscle is contracted due to the fact that they have a problem at the level of the joint. And in that kind of situation, maybe the best option is to try to relax the piriformis muscle with the Botox injection and to see if the pudendal nerve symptom disappear. Of course, you can try to stabilize the sacroiliac joint, but it's not easy. You need to have a surgery with the screws and many orthopedic material to try to stabilize. And it's not so easy. The results, I don't know if it's so good. But if the major issue is the pudendal nerve symptoms, maybe the best is to target the piriformis muscle.
If a patient had surgery on a tangle of blood vessels that surrounded the PN nerve, and it freed the PN nerve, but unfortunately it didn't fix the symptoms, is it possible to still go in for an entrapment surgery? And could it possibly have benefit for this patient?
what is the first step that the patient has? I didn't understand. They have a
It sounded like this patient had blood vessels that were tangled around the nerve, and
yeah,
it was released during a surgery, and unfortunately, it didn't really help with pain. I
yeah,
think
yeah.
she was just wondering if it's still possible to do something else, and
Yeah, of course. Of the patients are always in the research of the minimal invasive technique approach. But in one moment, if you are too minimal, it's not efficient or it's not enough. The idea behind that is the story of the dilatation of the venous system around the nerve. And one theory is that you have the pelvis congestion who gives the compression of the nerve. But for me, it's like the Tarlov cyst. The pressure inside the vein is not very high. And it's difficult to imagine that the venous pressure with just few centimeters of water is strong enough to compress significantly the nerve. But it's one of the theory to explain the pain is the vein who are dilated gives this kind of problem that some people try to clip or to embolize or something like that, this dilated vein. But of course, if it doesn't work, yes, you have still to try to decompress surgically the nerve. For me, you have still a place for that. Yes.
okay. And speaking of vascular issues, is there a correlation that you know of, or any connection between vascular nerve issues like May Turner's, pelvic congestion, and PN?
Um, the problem is maybe not in that sense. I think that many people, we are speaking at the beginning about pudendal neuralgia. Then after we realize that we have a functional problem, then we are speaking about pudendal nerve neuropathy instead of neuralgia. But after we realize that also a part of the patient had a pudendal arteriopathy, then some patients suffer from arterial compression and other had a pudendal venopathy, and they have some symptoms related with the venous compression. And sometimes we see something is the dilated vein, but in fact is not the origin of the problem, is the consequence of the compression. I give you an example. Many patients who have pudendal nerve entrapment, they have also hemorrhoidal problem. Why they have hemorrhoidal problem? Because the hemorrhoids have two exits, and one of the exits is the pudendal vein. Then if you block one of the exits, you create overpressure at the level of the hemorrhoidal plexus. Then probably is the explanation why you have this kind of problem. Another interesting remark concerning the hemorrhoidal problem. One of the treatment when you have hemorrhoidals and lesion of the anus is to give the NO mediators in the cream is the TNT, you know, the explosive that we use. Then you have some creams who free the NO. And if you look the mechanism of working of the tadalafil, it's reduce the destruction of the NO. Then we are using the same chemical mediator with the cream for the anus and for the tadalafil. That maybe is the relation between. It's two different clinical observation, but it's probably a link.
Okay. And then I have another question. This one's a little different. What do you think about the mind-body diagnosis? Can pudendal nerve issues be more of a central nervous system issue than a nerve or muscle issue?
That's a good question. In fact, the pain is what? It's just a small electric stimulation who run in the nerve, and then it's arrived in your brain. And after it's your brain who will consider what he has to do with that stimulation. It's the reason why the level of pain from patients to patients can be very different, because it's the interpretation of the brain. It's the reason why some control like yoga or the how do you call that? The exercise of relaxation can reduce the sensation of pain. The stimulation is exactly the same, but the interpretation of the brain can be different. And it's open all the space for the central nervous system. Then you have the how do you call that? The synchronization of the eyes movement, EMDR. EMDR is a technique of synchronization of the two part of the brain, who seems giving a good answer for chronic pain. The other thing is also the question of about the memorization of the pain, because when you have pain for years, maybe you finish to memorize the pain. And in fact, when the source of the origin of the pain disappear, you have always the sensation to have this pain. Why we have this theory? Because some some patient who had chronic pain, they present amnesia, one due to a stroke, another one after a seizure, and in these two patients, the pain disappear. Is the reason why we developed the theory that maybe we can have a memorization of the pain. What I'm doing when I'm in this situation, I propose to do reishi anesthesia. Then I sleep completely all the lowest part of the body. But if the patients continue to feel pain, it means two possibilities. The first one, the way of the pain is not the good one, is not through the medulla, and it can be maybe through the the autonomous nervous system. And the second possibility is maybe it's because you have the memorization in the brain of the pain. Memorization of the brain in the brain can be treated eventually by electroshock. You have more than 100 cases reported in the literature with the good results and relapse of the pain for sometimes years after the electroshock. But I'm not a psychiatrist.
So I have one question that I see in the chat. Someone asked, what do you think about spinal cord stimulators for pudendal neuralgia?
Well, that's very interesting. The question is always the same. What is the mechanism of what we do? And what we do, in fact, is exactly the same like the patients who have the pain, and they explain, when I put something warm or something cold on my perineum, the pain is decreased. What they are doing, they just superpose to the sensation of pain another stimulation. It can be a thermic stimulation with the cold or warm, or it can be an electric stimulation. Is the reason why some people does the TENS is a stimulation of the tibial posterior nerve with or at the level of the ankle, because this nerve moves to the sacral roots number 2 with one roots of the pudendal nerve. Then you superpose another signal on the pain signal. It means what? Yes, you will feel less the pain, but the nerve is still blocked, and then it's just a palliative treatment. My goal in the treatment of this pathology is, first, you have to decompress the nerve. You have to decompress the nerve, and the treatment is physiotherapy, postural control, and tadalafil. And eventually, Botox injection in the piriformis muscle. This is the first line of treatment of decompression. If it doesn't work, it's a surgical decompression. If this one doesn't work, you have all the space for the palliative treatment, like the drugs, the neuromodulator, the radiofrequency, or what you want. But the first thing is, when the nerve is blocked, for me, the most important is to decompress the nerve.
Okay, I think that's all. I think we finished it up. Thank you so much for your time and for, coming on and answering all members' questions. We really greatly appreciate it. I think that's it. Do you have any other comments you would like to add?
I'm open if you need to organize a second session of questions for your members. It's always interesting to transmit the information and to clarify the situation. But of course, it's impossible to answer to all patients. But we can organize from time to time that kind of open discussion. Is very interesting and funny.
It is, absolutely. Well, thank you so much. And I'm going to go ahead and stop the live. At least I hope I am. There we go. So it's still recording, but the live is stopped. And I will stop the recording.